This statement is to be read at the beginning of the program. Title of activity, peritoneal dialysis. Date is 10/23/15. Cooper University Hospital is an approved provider of continuing nursing education by the New Jersey State Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Successful completion of the program requires attendance for the full session and completion of an evaluation form. The purpose for this program is to provide the bedside registered nurse with the information and skills to perform peritoneal dialysis in a safe and efficient manner. The objectives for this program are differentiate between acute and chronic renal failure with regards to symptoms, treatments, and complications. Explain the differences between CAPD and CCPD. Discuss nutritional requirements of the renal diet. Differentiate between hemodialysis and peritoneal dialysis. Understand EPIC documentation specific to peritoneal dialysis. Demonstrate cycler and manual PD setup treatment completion. This activity provides 3.5 contact hours. There is no commercial support for this activity. The presenters for this program have submitted disclosure forms and I'm sorry? And have no conflict of interest. They do not intend on discussing non-FDA approved or investigational use of any product or device. And provider status does not imply endorsement by Cooper, the American Nurses Credentialing Centers Commission on Accreditation, or the New Jersey State Nurses Association of any commercial products displayed in conjunction with an activity.
Okay, good morning. Thank you all for coming and thank you for inviting me. Thank you for putting on this program. My name is Ron Zanger. You've heard it 3 times now. And I'm a member of the Division of Nephrology, and I'm the medical director at the DaVita Cherry Hill, and I run the peritoneal dialysis program there, and I've been doing it for probably more years and I care about probably over 25 years or so. But my goals today are really to give you a certain amount of comfort with peritoneal dialysis, and I think that if you have a certain knowledge base, then peritoneal dialysis won't be as intimidating, and that's sort of my goal. So today's goal, and if you find that some of it may be confusing, don't worry, because at the end of each of these topics, I'm going to give you a very concise one-line summary statement that I want you to take home with you to make sure that at least the important points are very clear and understood. But briefly, we're going to talk about how peritoneal dialysis works. Like any other dialysis modality, the basic goal of peritoneal dialysis is to eliminate fluid that the patient consumes during the course of the day, and solute, to remove the solutes that the generator consumes, otherwise known as the toxins. We're going to talk about the difference between CAPD and CCPD. We're going to talk about the different peritoneal dialysis solutions that you're going to be using. We're going to talk a little bit about PD catheters, and then we're going to talk a little bit about PD complications. So it's sort of a whirlwind tour of peritoneal dialysis. You probably have seen this, but I'm going to just show it to you again. This is the peritoneal cavity, and this is actually the peritoneal membrane in the red. And there are two names for it. It's the same peritoneal membrane. The peritoneal membrane that lines the organs, I knew I was going to problem, is called the visceral peritoneum, and the peritoneal membrane that lines the cavity of the body is called the parietal peritoneum. It's the same peritoneum that just folds over. Now the visceral peritoneum, which lines the organs, actually has much more surface area than the parietal peritoneum. But they've done studies in rats where they've taken out all the organs, and all they left was the parietal peritoneum, and PD works just fine. So most of the PD really occurs across the parietal peritoneum, because if you see, a lot of this peritoneum, even though it's a large surface area, is not available to the solution because it's all folded up inside. But important to remember that this is what the cavity looks like. This is the pelvis, and this is really where the peritoneal catheter sits. So this is what the different peritoneal catheters look like. They come in different conformations, and you'll see them in different conformations. As I showed you, the end is curled So if you look on an x-ray, and I'll show you some x-rays, you'll see this is curled. And they've done this because they found that it doesn't migrate as much, and it seems to function better. The catheter is manufactured with a bend in it, and that's called a swan neck, to prevent the cuffs from extruding. And you'll notice that there are, and I'll show you some pictures later, there are two cuffs. There's the internal cuff, which is buried in the rectus muscle, right, which gives you your six-pack. And then there is the superficial cuff, which is about 2 centimeters away from the exit site. The exit site is where the catheter actually exits the abdominal wall. That's called the exit site. And this superficial catheter should be at least 2 centimeters away from that, sometimes a little longer. What happens over time is the surgeon may place it 2 centimeters away, but the person loses weight. And then this superficial cuff starts to migrate out. And sometimes it actually just comes right out of the exit site. And that's okay. Patients can manage with just one cuff. Now, in obese patients, we don't want the exit site in a place where the pannus of the abdomen hangs over it. It's very hard to clean that. It's hard to keep it clean. It's a wet area. And so what we've done now, we've asked our surgeons to put in what we call upper abdominal catheters. And they've gotten our surgeon here is excellent at that. He will always make sure that the exit site is not in a bad position. And when we do upper abdominal catheters, the exit site actually comes up in the upper abdomen. And this is a titanium connector. So he'll actually use 2 PD catheters, connect them together, and now the cuffs, instead of being down here, will be up over here. So you'll see catheters coming out in thin people coming down in this area. You'll see them in this area, in this area. We had one patient who had one, it's called a sternal catheter. They actually tunnel it all the way up, and it comes out here in the sternum. And it's wonderful because it's so easy to care for. And in some places in the country, this is exclusively the catheter that's looked. So these are the configurations of the catheters that you're going to see. And this is what it looks like. I think you've seen the exit site. This is the transfer set. This is how you're going to connect to the PD equipment. This is the exit site. And the superficial cuff should be somewhere over here. This is an X-ray of contrast material that's injected through the PD catheter. Right? And as I showed you, this is the pelvis, this is the acetabulum, these are the hips, and this is the true pelvis. And this is where we want the catheter to sit, down in the pelvis. And when you inject contrast material, which would be the same as if you infused PD fluid, it should diffuse out freely and fill up the pelvis like this. If it doesn't do that, then sometimes it's wrong. And there are times when we have patients whose catheters don't work, and we will order a cathetergram, and we will ask interventional radiology to inject contrast. And then we're going to want to see how this catheter flows, how this fluid flows out. This is what we want to see. If we have problems, sometimes we see that there's a fibrin sheath around the PD catheter, and instead you see the contrast material essentially just tracking up and down the catheter and not diffusing freely. Or sometimes you'll see that omentum, right, which we used to call the policeman of the abdomen. It's a big it's a big apron of fat, essentially, that is in the abdomen and is used to actually seal off any abscesses that formed. You know, before we had surgeons, if a person had appendicitis, it would turn out to be fatal, but the omentum was designed to go to that area of inflammation, seal it off so the person could survive an episode of diverticulitis or perforation or something. So the omentum is a very active kind of apron with lots of, it's got a lot of fat on it, but it can move around. Sometimes it can wrap itself around the PD catheter, and when we inject contrast, we can see that. And that will be manifest clinically as a patient that has difficulty draining or sometimes even infusing. Okay. Now I'm going to give you, this is a little confusing, and if you find it difficult, don't worry about it. I'm going to summarize the important parts in 1 or 2 sentences. But I'm trying to give you a basic idea as to how PD works. You're going to learn how hemodialysis works. How does PD accomplish the goals that we want, which is eliminating fluid and eliminating the solutes or the toxins that accumulate? So I showed you what the peritoneal membrane looks like. So this is what it looks like under the microscope. This is the peritoneal membrane, and it's actually very, very thin. It's only 90 microns. there's a thin layer of cells on top of it called the mesothelial cell, and this is the abdomen. This is where the fluid in the pelvis sits, and here's the peritoneal membrane. And really, this peritoneal membrane, if you were to create a model where you strip this membrane off completely, this PD would work just fine. Because all it really serves, this membrane, is a hydraulic function. It's there to prevent friction from all the organs rubbing against each other. It really doesn't serve much in the way of peritoneal dialysis. The real action is not the peritoneal membrane, unless it gets abnormal, but it's underneath, which is the submesothelial level. And under here is where all the action is, okay? So underneath we have this tissue, and the significant part of the tissue is only about 1 millimeter. It's only 1 millimeter underneath the peritoneal membrane that is relevant as far as peritoneal dialysis is concerned. And I'll show you why that is. But in that tissue, you have a lot of different players. You have fibroblasts, which are connective tissue. You have some fat cells. You have some muscle cells. You have lymphatic cells. But most importantly, you have these little round things that are called capillaries. And that's the blood flow that goes through to the peritoneal membrane. And that's really where the action is. Because remember, you're trying to clean the blood. And the blood is here. And so somehow you've got to get the fluid out of these capillaries. You've got to get the toxins out of these capillaries. And it somehow has to find its way into the peritoneal dialysis fluid, because that's how PD works. So what happens is, we'll talk firstly about fluid ultrafiltration, because that's what you're going to be measuring. It works based on the concept of osmotic pressure. Now you should all know, I hope from your nursing courses, about osmosis, correct? Everyone's familiar with that? That fluid tends to move to an area of higher osmotic pressure. So we have very, very concentrated glucose solutions, and I'll show you how much glucose is actually in these solutions. Very, very high concentration of glucose. That glucose then permeates this tissue. And this curve describes the concentration of glucose as you go further down in the tissue. And as you can imagine, of course, as you're closer to this membrane, you're going to have the highest concentration of glucose. And then as you go further down, the concentration drops. And the reason only 1 millimeter is important is because by the time you get more than 1 millimeter, the concentration of glucose is so low that not much is happening. Okay, so most of the action is in the first millimeter of this tissue. And here the blood vessels now become essentially enveloped in this glucose. Okay, they're surrounded by the glucose. They're bathed in this glucose. And you have an osmotic draw, an osmotic pressure that takes fluid out of the capillaries and into the tissues. How it goes from the tissues into here is really interesting. I'm not going to, and we don't really know, believe it or not, how it goes. There's a great theory, but I'm not going to bother you with that. But just suffice it to say that fluid goes out of the capillaries into the tissues in response to the glucose that's in here and the gradient, and then moves into here. Okay, so obviously so that's essentially the movement of fluid. Now, everything, you probably learned about the Starling forces, but everything in these kind of systems is a balance of forces. You have one force pushing this way, you have another force pushing this way, and in the end, who wins? It's whichever force dominates over the other. So this is a force going this way, but you have another force that prevents that, and that's the pressure inside the abdomen. The pressure inside the abdomen is usually very low, about 2 millimeters. It's not very high. But when you start to fill patients up, you're going to increase the pressure. And as you can imagine, that is going to tend to push fluid in the way that you don't want it to go, which is this way. You're trying to get fluid out this way. And this fluid will get pushed in here, and it eventually winds up in the lymphatic vessels and back into the blood. And there is a constant flow. Unfortunately, this didn't come out very well. There's a constant flow of fluid out of the abdominal cavity into the tissues and into the lymphatics. And that flow is about 60 to 90 cc's per minute. So as long as the flow this way is greater than the flow this way, you're going to increase your ultrafiltration volume. Once you get to a point where this flow is equal to that, then your volume is going to stay level. And then once you get to a point where the fluid flow out of here is less than this, then the fluid volume inside the abdominal cavity is going to drop, and you're going to actually start reabsorbing fluid. So you'll go from 2 liters, would you put in, 2.5 liters at the peak of ultrafiltration. If you leave it in long enough, this is going to drop off 2.3 liters, 2.2 liters, 2.1 liters, 2 liters, you're going to wind up 1.9. At the end, you're going to drain. You're going to wind up draining less than you actually put in, and that's something that you don't want to see. Because the net goal is you want to get out more than you put in most circumstances. Okay, now what about the ultrafiltration of toxins? That's simply also going to go by, there's no urea, there's no toxins in the PD fluid. So there's a gradient for movement of toxins, urea, creatinine, potassium, etc., to move from a high concentration in the blood to a lower concentration in the PD fluid. And that's essentially how it works. Now I'm just going to, this is to show you a little bit more. This is where all the action is. This is the main barrier for ultrafiltration, are these capillaries. And you know that the capillary is just a blood vessel. And the inside of a capillary, the inside of a blood vessel, is called the endothelium. And so now this is a microscopic blow-up of the endothelium. And there are 3 pores through which fluid flows. There's the small pore, there's the ultra pore, and then there's the large pore. And the reason these are important is because when we talk about glucose, right, when we talk about movement of solutes, we talk about the movement of BUN, urea, or creatinine. It's a two-way process. Just like BUN and sodium and potassium and all these things, just like they can move out this way, well, the glucose in the PD fluid can also move into the blood vessel. It's a two-way street. And so if you start to absorb glucose, if the glucose is going in here and it starts getting reabsorbed, then the glucose concentration in your PD fluid is going to gradually drop and drop and drop. And there your osmotic gradient starts to drop off. So that happens at different points. It doesn't happen across this pore. It does happen across this pore. But that's the important thing to remember. So the take-home message that I want you to remember is, number one, that ultrafiltration occurs in response to osmotic pressure created by high concentrations of glucose. And we need very high concentrations of glucose because these pores are very, very stingy. They don't give up fluid easily. They only give up fluid if you create very high osmotic pressures. And that's why we use concentrations that are really, really high of glucose. And the other important thing to remember is that solutes move out this way, but that glucose moves into the blood vessels just the same way as solutes move out, and that the glucose concentration in the PD fluid therefore will drop over time. Okay. Now, we talked about one of the forces that forces fluid into the tissues, and that's the pressure you generate in the abdomen. Okay? And it's important to remember that the pressure is dependent on the position of the patient. So that when they're supine, this is how much fluid you're putting in. All right? As you're putting in more and more fluid, the intra-abdominal pressure is going to rise. But you see, it rises differently for different positions. So when a patient is flat, the rise in pressure is less than when they're sitting. The sitting is the highest position, and standing is sort of in between. And the reason that that's important is because when you put in a new PD catheter, the one thing you want to prevent is a high intra-abdominal pressure, because that surgical site is going to leak. And so you always want to keep your brand new PD catheter patients supine when they're doing PD. If they have to go up to the bathroom, you want to drain them, because remember, sitting is about the highest intra-abdominal pressure. Now, I showed you, we talked about solutes before, poison, the toxins. And this is just a very simple curve. This is really, really important because it sort of underlies a lot of what we do. This is simply time. This is the amount of time that you're going to leave the solution in the abdomen. Right? A 4-hour exchange is going to be 240 minutes. And this is the equilibration with the PD. So that when you start off, the concentration of urea in the PD fluid is 0. There's no urea in PD fluid. And the concentration in the blood is going to be, let's say, 100. And then over time, as it sits in there, urea starts to move into the PD fluid. And we call this the saturation. The concentration now, at this point, it's 60% saturated, which means the concentration in the PD fluid is 60% of the blood. At this point, it's 80% of the blood. And at this point, you get close to 100% of the blood, which means the PD solution is completely saturated with urea. And this is about as efficient as you can get because you've used your time very, very effectively. Now, why is this so important? Firstly, you should know that creatinine, for example, is a larger molecule. So at any given time, the saturation is going to be less. It takes a lot more time for creatinine to get to 80% than it takes urea. Urea was able to get there in 100 minutes. Creatinine didn't get there until it was 240 minutes. So the other important thing to remember is that large molecules require more time to be eliminated than small molecules. Okay? And the other thing to remember is that you're going to be doing two different types of dialysis. You're going to be doing CAPD, and you're going to be doing the cycler. And the main difference between these two we're going to learn, as I'll show you later, is time. The cycler are short dwells. Dwell is simply the amount of time that the PD fluid is actually in the abdomen in contact with the peritoneal membrane. So when you're doing a cycler, you're going to get, let's say, a dwell of only 120 minutes. So you see that CCPD is pretty inefficient. Because at this point, when it gets drained after 120 minutes to go to the next cycler, it's not going to be completely saturated. Where CAPD is very efficient because it sits in there for 6 hours. And at that point, you get a lot more saturation. Okay? And I'm going to show you how we have to compensate for that. So it's going to be especially affected for small molecules like creatinine. Creatinine is not going to be eliminated very well with these really short dwells. And that's why a lot of our patients on CCPD, they come in with creatinines of 18, and everyone says, oh my God, they're under-dialyzed. They're not under-dialyzed. It's just the nature of the dialysis. Now, we are all different. Some of us are tall, some of us are short, right? Everyone's different, and everyone's peritoneal membrane is different. And it's important for us to know, and it's going to be, you'll see why it's relevant to you, to know how a person's peritoneal membrane performs. I showed you the effect of the time course of equilibration for the different toxins, but that's going to differ. There are some people who we call high transporters or fast transporters. And then there's some people who we call slow transporters. Okay? So that if you look, these are the exact same curves I showed you before. And this is the DP, this is the saturation again for urea, which I showed you, and creatinine. And you're going to see that the high transporters, because they transport solutes really fast, so at 2 hours, they're going to have a lot of saturation with the toxin, whereas the slow transporters are going to have a much lower one. Now, why is that relevant to you? Why is that important to you? Because I told you earlier that what causes ultrafiltration of fluid? It's the glucose. It's the glucose concentration in the PD fluid. And I told you that the movement of solute is a two-way street. It's bidirectional. So just like these high transporters transport urea into the PD fluid fast, they transport glucose back into the blood just as fast. So what's going to happen to that patient? That patient who's a high transporter is going to lose the glucose osmotic pressure in their PD fluid much faster than somebody else. So you take a patient like that and you put them on CAPD, for example, right? And you give them a 6-hour dwell. Well, by that time, because they're so efficient, the glucose gradient is gone, you're going to start absorbing PD fluid. Whereas if you did that to a low transporter, they're going to ultrafilter like a champ because they're able to maintain the glucose gradient. So different patients are going to respond to the different modalities, CCPD and CAPD, differently, because number one, those are different times, and dwell time, is so important based on your transporter status. So that's an important point. Does everyone understand that? Okay? And you're going to see that clinically. You're going to see different patients ultrafiltering in different ways. And so that's one of the ways. There are a few other ways that will affect, but that's a very important way. So what we do in every one of our PD patients, when they first start in the outpatient clinic, one of the first things that the PD patient nurse will do is something called a PET study, because we want to know whether a patient's a high transporter or a low transporter. And so every patient, we know already, by the time you get them in, let's say with a complication, we already know whether that patient's a high transporter or not, because we study every one of them within 2 months of starting our PD program. And that's important for us to know. Oop. I think I pushed the wrong button there.
Did you? Oh yeah, you went way ahead. We're going back. Sorry.
Okay.
That's where you were,
Yeah,
right? There you go.
thank you. Okay, and so again, just to show you what I just graphically, just to show you what I explained to you, this is, we know, so now we've learned 2 ways that we can affect ultrafiltration. So this is simply the curve of ultrafiltration. Patient starts off with this volume, and this is time, and this is the volume in the abdomen over time. All right, so this is a 4.25%, a very concentrated solution, and this is a 1.5. And as you can imagine, the more glucose you have, the more you're going to ultrafilter. So these patients will ultrafilter a lot. If you use a concentrate of 4.25, that's a very concentrated glucose solution, you're going to get a lot of ultrafiltration. You're not going to get a lot, don't expect much if you're using 1.5%. Not only that, at this point, this patient's already starting to reabsorb. So you see, by this time already, at 240 minutes, which is 4 hours, the patient with a 1.5 actually has less fluid in the abdomen than you put in. They start to absorb because the glucose concentration was so low. Whereas the patient with a 4.25, you put him in, you may have started with 2,400, that patient's already still ultrafiltered 600. So number 1, glucose concentration will affect your ultrafiltration. So if a patient was volume overloaded, the doctor is going to order a more concentrated glucose solution to try to get fluid off. Now let's look at that same thing based on transporter status. Okay? Here's the patient who's a rapid or a fast transporter. Right? So what's going to happen to that glucose gradient? It gets dissipated quickly. They're going to absorb all that glucose. Yeah, so they start to absorb, but now they start to ultrafilter, but after a relatively short period of time, all that glucose is gone because they've absorbed it so fast. And now they start to absorb fluid. Whereas the patient who's a slow transporter, they maintain that glucose. That glucose stays there. It doesn't go anywhere. So they ultrafilter, and they keep that glucose in there, and they keep ultrafiltering for a long, long time. So we've learned 3 ways now in which ultrafiltration is going to be affected in our patient. Number 1, the hydrostatic pressure. If you generate too much intra-abdominal pressure because you're putting in too much fluid, that's going to push fluid into the tissues. Number 2, the glucose concentration. Number 3, the transporter status. How do you know if if the intra-abdominal volume is too high? You simply ask the patient. I always ask my patient, first thing I ask them is, when you do your exchanges, are you uncomfortable? If the patient tells me, I feel full, I feel like I'm going to have a baby, that's really uncomfortable, I always reduce the volumes. I never want patients to have that sense of feeling, because that also means that the intra-abdominal pressure is probably too high. And it's also, at night, it wakes people up if they're getting too much volume, because remember, you may start off with 2,500, but when they're going to ultrafilter, they're going to have 3,000 cc's at some point, and that can be very uncomfortable. So I always reduce the volume. You'll find that even if you just reduce the volume by just 100 or 200 cc's, that's all the difference for a patient. We never want patients to be uncomfortable. Now, we're going to talk about the different types of dialysis. So CCPD is going to be cyclers at night, rapid cycles. And these dwells are short. They're about 120, maybe a little bit more minutes. And then you can do it 2 ways. 1, you could leave them dry during the day. Usually we do CCPD at night, right? Because we want to give people freedom during the day. You have 2 options. 1, you can leave them free and the abdomen empty during the day. Or you can leave them with a long exchange during the day. So why do we need a long exchange during the day? Well, because I showed you that short exchanges are good for removing small molecules, but they're not very good for removing large molecules, because large molecules require time, right? And this is one thing that you're not getting with CCBD, which is time. And why is that important for us? The reason is because we don't even know what molecules cause uremia. Urea, believe it or not, is not toxic, right? I could get your urea level up to 120 if you have normal kidney function, and you'll feel perfectly fine. Urea is not toxic. Creatinine is not toxic. We know, however, that when the BUN is high, people tend to get sick and uremic. So something, the size of urea, whatever it is accumulating. So urea is simply a marker for a small molecule that we're removing. We don't know what we're removing exactly, but we know that we need to remove molecules probably the size of urea and probably the size of creatinine, which is a larger molecule. So we want to make sure that we're getting all those molecules. So we use a long dwell during the day because that gives us a little bit more of the middle molecule clearances. Okay? Now remember, what's the problem you're going to have here? If you leave a glucose solution in for 10 hours, what's going to happen? You're going to reabsorb it. So that's a struggle for us. And then we'll talk about how we overcome that. Now, some of our patients, for example, they're very big, and we're not getting enough urea removal. There are ways that we measure that. And so what we do is, this is a long interval. This can sometimes be 10 hours. And I showed you that the saturation is probably done by 5 or 6 hours. So the additional 4 hours isn't accomplishing anything. We leave it in simply for convenience because patients don't want to be bothered to drain it. They want the machine to drain it when they go on. But sometimes we have to take advantage of that, and we ask them to do a midday exchange. And then we get a little bit more dialysis in. So this is about the most dialysis we could do is using this technique. And this sometimes in patients that are very large. The larger the person, the more fluid we tend to need to be able to get adequate dialysis. Now, one thing I didn't include in this slide, I should have, just CAPD. CAPD is a very simple way, and that's simply 3 exchanges during the day and 1 overnight. Right? We put it in at 8 in the morning, we'll put it in at 12 in the morning, and then at 4 or 5 o'clock, and then one before sleep. Each exchange is about 5 or 6 hours. It's about as simple as you can do it. It's what's done in most of the world because it's a much cheaper way of doing dialysis than cycler PD, and much, much cheaper than hemodialysis. So in the third world, PD is used extensively. Not in this country so much, but in the rest of the world it is used extensively. Now what about the nature of our PD solutions? What's in these solutions? So we don't put potassium in it because we want to make sure there's a high pressure for removal of potassium. It's lactate-based. We don't have bicarbonate, and that's not biocompatible. All right? So now recently there's been a movement to get rid of lactate and use bicarbonate, and that's called biocompatible solutions. It's not approved in the United States. It's used extensively in Europe and in Asia. I don't know if it's ever going to come to the United States because it's more expensive and nobody wants to spend money, and there isn't enough data to suggest that it makes that much of a difference. Very high glucose concentrations, right? The normal concentration of glucose in the blood is 100 milligrams per deciliter. That's what your blood sugar is. Look at these concentrations. These are really, really high. The reason we use it is because I showed you those pores from which ultrafiltration occurs are very stingy. They need really high osmotic pressures. Okay, so these are very, very concentrated glucose solutions. The solution is very acidic, and that can sometimes cause pain when you infuse the patient. So the newer biocompatible solutions have pHs of 7. All right, we don't have that. We have these more bioincompatible solutions. The calcium now is not 3.5, now it's 2.5. We don't use these solutions anymore. So there's one other solution. Now we don't have this on formulary here, but almost all our patients use it for the long dwell. We talked about the long dwell on CCPD. And the problem we talked about is that they're going to absorb it if it sits in there too long. Now, it's a real double whammy because you're absorbing all the glucose if it sits there for 10 hours. You're getting all the calories and all the negative aspects of absorbing all that sugar, and you're not getting anything for it. You're not ultrafiltering anything because in the end, you wind up absorbing the fluid. So glucose for long dwells has never been a good option. And so they came up with a new solution, right, which is called Icodex, which our patients know as the purple bag, right, because all the bags are color-coded, right? We know them as yellow bags, green bags, and red bags. They know this is the purple bag. And almost all our patients use this for the day dwell, and when they get hospitalized, they will often bring in their own Icodex. So you will be using it, you will be using their solutions. And essentially what it is, it's starch, essentially. It's cornstarch. Right? And we're a country that produces more corn, I think, than any other country in the world, and yet I don't know why this is so expensive, but it is. But it's really cornstarch. So let's look at ultrafiltration. This is a curve that should be familiar to you by now, and let's look at Icodex. So this is time, this is dwell time, and this is ultrafiltration volume. And so this is, and you know what transporter. So this is a high transporter. And you can see the ultrafiltration volume goes up and comes right down really fast because they start absorbing fluid. Here's a low transporter, does a lot better. Ultrafiltration goes up, comes down eventually slower, but much, much better than the high transporter. Look how Icodex behaves. This is the proverbial hair in the tortoise. Ultrafiltration is slow and steady all day long because the Icodex is not absorbed. It's always there. And so you just constantly filter all day long. It's wonderful. Okay? And so it's great for helping manage fluid management and especially helping avoiding these problems of ultrafiltration. And the really great part about it is it does not change hemoglobin A1C. It does not make blood sugar go up, which obviously these things do because they're glucose-based. So metabolically it is friendly and it is very good for ultrafiltration. And there was a time where they made it restrictive because it was so expensive, but now they realize how beneficial it is and it's really worth the money, and it's used extensively in all PD units. Now, what do you have to worry about when you're using icodextrin? There's certain precautions. The first one is the serum amylase. So this is a patient who's getting, this is the serum amylase in a patient who's getting dialysis with just 2.5% dextrose. This is the serum amylase. And this is what happens when you start a patient on icodextrin. The amylase level goes down really low. Okay? And it's why that happens is, we're not going to talk about today, but the reason that that's important is that you cannot use amylase to diagnose pancreatitis in a patient who's on icodextrin. You have to use lipase. The doctors may not know that, so you have to make sure. Doctor, you can use amylase. Okay. Now, the other very important precaution is that the metabolites of icodextrin that are absorbed can sometimes cause false positive readings on certain glucometers. And so every patient has a bracelet that only certain glucometers can be utilized. Okay? And there's a website called glucosafe.com that tells you what glucometers are safe. But it's very important that they only use the right one. The ones that you have to avoid are the sticks that use glucose dehydrogenase. I don't know exactly what we're using here. We should really make sure that that's fine. But the patients all know when they start, the first thing we do is check the glucometer, because otherwise you'll get a false positive reading. You'll give them insulin, and there have been deaths associated with creating hypoglycemia in people who made that mistake. Very important. The other thing is I showed you how well it ultrafilters, so you can actually cause dehydration or volume depletion in your patient. You have to be careful. Skin rash is common. Sometimes we just keep treating and the skin rash goes away. And hyponatremia, it's not worth talking about. Now, what can cause problems with ultrafiltration? This is what you're going to expect with icodextrin. You're going to expect a positive ultrafiltration all the time, even if you leave it in for 10, 12, 14 hours. However, what they found recently, this is only 2014, is that you expect your cycler, by the time it's finished in the morning, to have drained all the fluid out of the patient. When you have that last cycle, you don't expect that there's fluid left. The cyclers aren't great at emptying the abdomen, and sometimes they do leave fluid behind. So when you infuse the icodextrin, that icodextrin gets diluted, and it's not as effective anymore, because now it's not as concentrated a solution. And so if there's a high residual volume, which is what we call that volume that's left behind, that will affect ultrafiltration on icodextrin. And it affects icodextrin much more so than glucose solutions. Okay, so this is the residual volume. This is how much is left behind before you put in the icodextrin. And this is the ultrafiltration. And you see, as the residual volume is higher, meaning you're leaving behind more at the end of your cycler therapy, the amount of ultrafiltration really drops off dramatically with icodextrin, not so much with glucose. So that will sometimes affect the ultrafiltration that you get. And what happens if you wind up not getting adequate ultrafiltration? Obviously, these are things you know. You're going to get a lot of edema and congestive heart failure. And so volume management in PD is always a challenge. In hemo, it's so easy. You hook them up, you push a number in the machine, and it takes off whatever fluid you want. It's not as dramatic with PD. And it takes a little bit more work to make sure that it happens correctly. Now, these are the catheters that I showed you. Okay? So this, again, just to show you the PD catheter. This is the rectus muscle. This is the fat tissue underneath. This is the exit site. This is the superficial catheter, the superficial cuff, which you can actually feel under the skin. And this is the deep cuff in the rectus. Sometimes what we do is we bury it. I mean, can't see it here. But the surgeon, instead of, when he put it in here, instead of taking it out, he buries it under the skin in the operating room. And so the patient, you don't see anything. And then they go home and we follow them. And then when the time comes for dialysis, we simply make a little nick. We pop out the catheter, and they're ready to go. And that's called an embedded catheter. It's a wonderful thing to do. And make sure that your patient has a catheter when they need it. Now, talk a little bit about exit sites. What's the ideal exit site? The location, we talked about we don't want it in an area where there's fat, where there's a pannus, where there's fat hanging. The color, it's usually flesh colored. A new catheter is going to be a little bit red. The sinus tract, actually I should go back. I forgot to tell you what the sinus tract is. This is called the sinus tract. The space between the exit site and the superficial cuff is called the sinus tract. And when you lift this catheter up, right, and you peek underneath, you should see strong epithelial squamous tissue growing into that sinus tract, which you will look right in there, right? You lift it up, you should see strong epithelial tissue, skin essentially, growing in there. You shouldn't see any reddened area. You shouldn't see, weeping tissue at all in a healthy exit site. You shouldn't see any drainage. And sometimes you can see a little bit of crust, but there really shouldn't be any crusting at all on the catheter. But these are the types of things that you will see in exit sites that are not really optimal. And we classify them. We don't say, okay. We actually have a very strict criteria as to how to classify them. There's actually a manual of pictures I'm not going to bother you with, but we teach that to our fellows. We classify them as perfect, good, equivocal, chronically infected, or acute infected. These are other things, but these are essentially the four terminologies that we ask our fellows to utilize. And we teach them, we try to teach them at least, the different criteria for how to define these. But these are the things that you're going to look for when you're assessing the exit site. Now, what are the goals of dressing changes and procedures when you have a new catheter post-implantation? The most important thing you could do for us, you know how it is with the surgeons. They do a procedure, and they come by, the residents come by at 5:30 in the morning, and what's the first thing they do? They look at the dressings, they want to look at the wounds. You don't want to do that with this. We want to prevent colonization during the early period. Leave that dressing on for at least 3 or 4 days, okay? Don't let any surgical resident do that or touch that. That's the last people we want touching these things. So just leave it covered for at least 3 or 4 days. The first dressing change has to be done with mask, cap and gown, in a very sterile way, because we don't want that exit site to be colonized bacteria. We want it to heal normally. And we want to make sure that the catheter is well immobilized, because motion will prevent granulation tissues from growing in and healing the catheter. So you want to mobilize the catheter, and you want to keep it covered at least for 3 or 4 days. And only have a person who knows what they're doing that first exit site cleaning. So you want to restrict care to experienced PD staff. You're going to use aseptic technique for that first exchange. You want to avoid toxic solutions. We use something called Accept, which is a dilute bleach solution, which is wonderful. Sometimes our patients actually bring it in. They don't have it here, but even if you use soap and water, but just don't use the toxic things. You want to keep the dressings dry. You want to mobilize the catheter. Once the exit site, after about 3 weeks, is healed, that's when we have the patient start doing the normal exit site care. And what they do is they simply take a shower and they clean their exit site with soap and water in the shower. If you see scabs on it, don't pick it off, don't take it off. This is kind of obvious stuff. Now, antibiotic ointments. We put on, for all our patients, we recommend an antibiotic ointment at the exit site. We used to use mupirocin. Recently, there was some evidence showing that gentamicin cream is a little bit better, so that's what all our patients use. I'm not sure there's that much of a difference. You can use whatever you happen to have, but all of the patients should have, part of the exit site care should be an application of one of these antibiotic creams to the exit site. What is an exit site infection? If you see redness or skin induration or purulent discharge, crust. Now, if you see crust, that may not mean an exit site infection. And if you have positive cultures, if someone cultures the exit site, but there's no inflammation, that doesn't mean anything. So we really avoid, misleading people by culturing sites that we don't think are infected. So let's talk briefly about peritonitis. Peritonitis is one of the dreaded complications of PD is an infection. Because as you imagine, we're doing all these exchanges, there's a risk of infecting the PD fluid and getting peritonitis. And the hallmark of that is going to be cloudy fluid. What we teach our patients is, they're very good at this, the way to decide whether your fluid is clear or not is simply take the bag, the effluent bag, you put it on a newspaper on the floor, and you should be able to read relatively small black print through the bag, relatively clear. And if the fluid is clear, you don't have to send a cell count. They don't have a PD infection, okay? So just, is the fluid clear or not is a very good marker as to whether or not you have peritonitis. There is culture-positive peritonitis, and there is culture-negative peritonitis. Some of this is probably due to collection techniques. We try to keep this low because it means that we're not doing things properly, but as far as either in the lab or collecting it. But sometimes you can get cloudy fluid, and it's not peritonitis. It's not an infection. It could be either because of the additives we use, or because there's blood, which is sometimes you see in menstruating women, or a dry abdomen. If the abdomen has been dry for a long time, you haven't been using it, and then you try to get a little bit of fluid out, that fluid is going to be cloudy. That doesn't mean anything. Now, what's the diagnosis? How do you make the diagnosis of peritonitis? Number one, you have to have abdominal pain. Number two, the white blood cell count of the PD fluid has to be over 100, and it should be at least 50% polys. That's the criteria for peritonitis, okay? Now, you want the dwell to have been there for at least 2 hours. Otherwise, these criteria don't work as well. So if you have a very short dwell, you may have to infuse a fluid, leave it in for 2 hours, and then send it off for a cell count. The Gram stain is done. It's not that helpful in bacterial peritonitis. It's very helpful in identifying yeast. The only time we see yeast for the most part is after a patient has been on antibiotics for peritonitis. So the major risk factor for developing yeast in the PD fluid is a previous episode of peritonitis, treatment with antibiotics, or probably treatment with antibiotics of any sort. We generally don't do blood cultures because this is a local infection. It is not a systemic infection unless they're toxic. And we don't do CAT scans unless it's localized, in which case we think it might be due to appendicitis or diverticulitis. But if the pain is diffuse and it's a typical story, cloudy fluid, we don't do CAT scans routinely. Unless if they come to the ER, they're going to do a CAT scan anyway. Now, sometimes you can see free air on the X-ray, and that doesn't necessarily mean there's a perforation. Sometimes free air is introduced from the exchange. And how do we work them up for peritonitis? You'll take PD fluid, you inoculate 2 blood culture bottles, they centrifuge it downstairs, and they plate it on blood culture media. Okay? Now, what are the causes of peritonitis? Well, there's contamination, and most of them occur during the exchange. And that's why it's so important to wear masks. That's probably the most important thing. And I have seen nurses, unfortunately, when they're really rushed, they'll do an exchange and they'll forget to wear a mask, or they'll forget to put the mask on the patient. Lots of time the patients will tell me that. So that is far and away the most important thing. Always, whenever you're opening the system, you must always have a mask. Anyone in the room, try to get everyone out, has to have a mask. Anyone in that area and the patient must wear a mask, always. If at home sometimes, if it's in a dusty area and there's a lot of wind blowing, they can get contaminated. Pets can cause peritonitis, usually because they gnaw on the tubing. Believe it or not, there's a whole article written on pet-induced peritonitis. And also, the more exchanges you do, the more on and off you make, more connections you make, the greater risk for peritonitis. Sometimes you can get peritonitis due to transient bacteremia. This is rare from dental infections, right? If you have a dental surgery and you get in the bacteremia, you can see the peritoneum. These are uncommon intravascular devices. And sometimes you get a biofilm. The PD catheter they all get biofilms. If you take a PD catheter out, they all have fibrin on it to some degree. Sometimes the bacteria can get lodged in there and you just can't get them out. And these people have recurrent peritonitis and you have to take the catheter out. Now, so contamination in skin and environmental pathogens is one cause. The other important cause is the exit site infection. Okay? So one is associated with a catheter infection, the other one is not. And that's very important. So here is a situation where you have peritonitis in conjunction with an exit site infection. And the reason that's important, that these are often Staph aureus, Pseudomonas, and they often don't resolve without removing the catheter. So those infections tend to be much more serious than if it was simply contamination. And how do you distinguish between these two things? You simply look at the exit site. If the exit site looks normal and fine, then it's probably contamination. If the exit site looks infected, then it's probably due to this. Okay? Other causes of peritonitis is hypokalemia. Hypokalemia causes motility problems in the gut, and you get overgrowth. And overgrowth causes increased permeability of the GI tract, and you get movement of bacteria from the GI tract into the peritoneal fluid. So we like to avoid hypokalemia. Colonoscopy. For all our patients who have colonoscopy, we give them triple antibiotics IV because they can transmigrate fluid from the colon into the PD fluid. Constipation. Always ask your patient about constipation because A, it causes catheter dysfunction, and B, it is a risk factor for peritonitis. We don't ever want our patients to be constipated. Okay. These are the organisms that cause it. I can say in all these years, this is coag-negative staph, which is most common. I don't think I've ever seen a case of coag-negative staph. With the new technologies that we have, we just don't see these infections anymore. Unfortunately, a lot of them are staph and gram-negatives. And these have a much lower yield of success. What's the overall success? And by success, I mean resolving the peritonitis and saving the catheter. 79% of the time we're successful. About 18% of the time we're going to lose the catheter. Many of our patients who have peritonitis don't make it into the hospital. We treat them as outpatients. If they're not all that sick, we give them antibiotics and we treat them as an outpatient. And then we retrain them. So what about resolution? How do you identify someone who's going to get better or not? So if you have a purulent exit site, if the exit site is infected and that's the cause of peritonitis, the risk of losing the catheter is much greater. This is the resolution. 65% will resolve. If the exit site looks good and is normal, 82% will get better. So if you have an exit site in peritonitis, that patient's in trouble. That patient is a patient who may not get better. So how do you identify your patient? Let's say you have a patient. How do you identify a patient who's heading in the right direction or who's heading in the wrong direction and heading to the point where he or she may need that catheter removed? So the cell count is the most important variable, as well as the resolution of pain. So if your cell count is greater than 100 for over 5 days, then non-resolution is about 45%, which means 45% will not get better. You're going to have to remove those catheters. If at the day number 5, the cell count is less than 100, only 4% lose their catheter. So that's a really good way. On day number 5, if your cell count is less than 100, you're in good shape. If it's over 100, you have a problem. So the problem is, do you have to wait till day number 5? So they actually found that you can actually have a marker on day number 3. On day number 3, if the cell count is greater than 1,090, then that's associated with a 9-fold risk of treatment failure. So it's a very good test, day number 3. Now the reason I mentioned this to you is twofold. Number one, shows you how important that cell count is for us, because you're going to be collecting the cell count. Without that cell count, we're flying by the seat of our pants. So it's so important to get that cell count in the morning so we know where things are going. And also, this gives you an idea, so you have an idea now yourselves as to how your patient's doing. If you can see on day number 3 that the cell count is 1090, then you know you've got a patient that is going to has problems and may wind up losing that catheter. And what are the indications for removing the catheter? If on day number 5 the cell count's over 100, then that's an indicator. That's a refractory peritonitis. Or if the peritonitis comes back within 4 weeks of a recent course of therapy. Many of these patients have the bacteria in the biofilm that sits in the PD catheter, and that just keeps coming back until you take the catheter out. Or if you have a tunnel infection, and sometimes we'll do an ultrasound of the tunnel, which is this with the space that the catheter runs in the abdomen. And if we see fluid, when you do an ultrasound, it should look like this. The catheter is in the middle, and the tissues are above like that. But if you see this, if you see 1 millimeter stripe between the tissue and the catheter on the ultrasound, that means you have fluid in there. There shouldn't be fluid in there, and that's a tunnel infection. And very often those patients, if they have peritonitis, are not going to resolve until you take the catheter out. If they have fungal peritonitis, we always take the catheter out right away, immediately. How do we treat? Antibiotics. We prefer to use intraperitoneal antibiotics because these are local infections, and this is where we want to keep the antibiotics. These are not systemic infections or bacteremias where we need systemic infections. If they look toxic, of course, and maybe it might be a systemic infection, then we'll use IV antibiotics, but IP antibiotics are preferred. Rarely we'll use PO. The quinolones can be used PO. Now, you're doing CAPD and CCPD. If you're going to add antibiotics to your PD, you have to use it in a long dwell because it takes time for the antibiotic to be absorbed and to sit in there. So you can't ever put it in the CCPD bags because those dwells are much too short. So if you have a CCPD patient, you'll put it in the long day dwell. If you have a CAPD patient, you can put it in each bag because each dwell is long. And that's probably the best way to do it, is to have a patient on CAPD with peritonitis and put antibiotics in every single bag. Okay? With CCPD, what we do is we just put one loading dose in the long dwell, and we do that every day. Now, this is the last slide. What are the complications that we see with PD? Mostly related to the glucose. We get hyperglycemia. Insulin levels are high, which has other consequences. All our patients gain weight because they're absorbing all these calories from the glucose. The triglycerides are elevated, and that's why we like to use Icodex, because it doesn't have a lot of these metabolic complications. Membrane effects. I showed you that the solution we use is not biocompatible. It's a low pH, it's got lactate, and that affects the membranes. And these are the things that damage the membrane over time. And over time, if you use high concentrations of glucose, the membrane itself gets damaged, and its ability to function deteriorates. And that's it. So it's a whirlwind tour of dialysis.
Does anybody have any questions for Dr. Zanger?
How does that get filtered through the...
So some meds are removed and need dose adjustments, and some don't. How do you know? You look it up. I have a little book that's called The Dialyzability of Medications, and you're right. And but you should have those. You should have those. You have Lexicon, and I use Hippocrates, and all these little devices have a little section in all the medicines as to whether dose adjustments are needed for hemodialysis and peritoneal dialysis, CRT and all. But everyone has to take the time, unfortunately those don't always happen, to check. The biggest medicine, I will tell you, that causes problems in all our dialysis patients is gabapentin. Okay? The normal dose of gabapentin is astronomical. You can use 600 milligrams or so 4 times a day. The dialysis dose of gabapentin is 900 milligrams a week. Okay? And so everyone misdoses. We have so many hospitalizations that occur just from that medicine because someone gave this person the normal dose of gabapentin, and they come in, they can't walk because they were overdosed on gabapentin. So just always be careful. That one drug for some reason really is the problem.
The catheter can be used same day, or do they have to
For a new
wait?
catheter? Yeah. So it all depends how it's placed. There are many different ways of placing, but in general, our surgical catheters, because they're placed surgically, are not used right away. There are other ways of doing it. For example, I used to do my own PD catheters, and we did it with a technique of just dilating tracts, and then you could use it right away. But the way that it's done surgically, for our catheters, we tend not to use the catheter right away. We try to, if we can, wait a couple of weeks. If we have to use it right away, then we only do it in the supine position because the pressures are much lower, and we use very low fill volumes.
So usually wait a few weeks.
We'd like to, yes. Yeah. Because if you get a leak, it just becomes messy.
You were just saying about the gabapentin. Is it to give it or not give it?
Yeah, you can use it at the right dose. So we use it, for example, we'll use 100 milligrams, 200 milligrams a day, not more. But it's a drug that is so commonly used at such high doses, and everyone thinks it's so benign, but it's not so benign if you use it in the wrong dose in a dialysis patient. And since it's so commonly used, it seems to...
Any kind of dialysis patient?
Yeah.
So if we see the doctors, maybe apologize.
Yeah, you should gently, politely.
Thank you very much.